Good morning, everybody. I see that it's 7:02 a.m. I'm going to go ahead and start our 7 o'clock refresher course. Thank you to my vast audience for getting up early this morning to hear me talk about, by the way, I have an LVAD. I'm Michael O'Connor. I'm from the University of Chicago, and today we're going to be talking about left ventricular assist devices. I have no relationships with any of the manufacturers of these devices, or frankly, the manufacturers of anything. Unfortunately, you can't talk about these devices, generally speaking, without talking about specific devices, so we're going to actually refer to specific devices in my presentation. First of all, can you raise your hand if you've taken care of an LVAD outside the operating room? All right, very good. So we're going to talk about the anatomy of these devices today. We're going to talk about the indications of these devices for today. We're going to talk about how these devices change a patient's physiology. We're going to talk about the complications of implanting these devices, because that's what we do a lot of work with. We'll talk about the clinical implications of all of this, and we'll talk about when it's time to stop. And so the first generation devices are the HeartMate XVE, which is no longer in use, the Thoratec PVAD and IVAD, both of which are still out there, the Novacor LVAD, which is also still out there, and the CardioWest Total Artificial Heart, which is probably increasing in popularity nationally and internationally. The problem with pulsatile devices is that they have valves, and valves fail over time, and so the second generation devices are originally referred to as non-pulsatile. Now people talk about them as continuous flow. There are second and third generation devices. Second generation devices have bearings somewhere in their design, and third generation devices do not. And so the most common, by far, LVAD implanted in the world is the second generation device, the HeartMate 2. We'll take a look at its bearings in just a few minutes. The HeartAssist 5 is actually in trials. The third generation devices all are what we call bearingless devices. They don't have a bearing that will fail over time. It sounds really silly, but if you plan for these devices to spin at thousands of RPM for years without stop, they can't have bearings because bearings fail. The Heartware 3 is in, the Heartware is a third generation device that's out there. The HeartMate 3 is in clinical trials. It's likely to be a major player, and the MVAD's also in clinical trials. This is the Thoratec device, which we used to implant a lot of at my shop. Most of the time, on the left side, they're implanted with the apex in the LV, excuse me, the inflow cannula in the apex of the LV and the outflow cannula in the aorta. There are a variety of ways that they can use it, either singly or in concert. This is what one looks like on a countertop right here on the left. And on the right side, I've got an x-ray of one of our patients who actually has one in. A couple of comments about this, one of which is, with one exception, all of these devices actually have to suction blood out of the left ventricle. So they generate a negative pressure that can actually be transmitted through the left ventricle into the left atrium, even into the pulmonary veins. As a consequence, people have a VSD or an ASD. These things need to be closed, otherwise you will have a huge rate of paradoxical emboli with almost all of these left ventricular assist devices. The other thing is that there's a significant resistance in the outflow cannula of all these devices, so the device is generating a much greater pressure at the outflow of the device than you'll measure in the arterial circuit, because there's a huge resistance loss of pressure through the aortic cannula of these devices. This is the HeartMate 1 XVE. It's actually my all-time favorite device. It's about as big as a small dinner plate. It's actually implanted in a patient's abdomen. What did I like about this device? I liked the fact that you did not require anticoagulation for this device. The second thing is that it basically gave the patient as much cardiac output as their right ventricle was generating. It was a fabulous device. I'm sorry it's gone, but it's gone. This is the pulsatile device of the future. It's the CardioWest Total Artificial Heart. On the left side is a photograph taken from that stone paper that I reference here. When you implant this device, you basically excise the patient's ventricles and anastomose this device to their atrium, their pulmonary artery, and their aorta. So they have no ventricles. On the right side is a chest x-ray of one of our patients that actually had one of these devices in. I don't know if you can see it well here. Here's my pointer, I guess. You can actually see the valves of the device and basically air where there used to be heart in this patient. On the bottom of the screen right here is what the monitor looks like. Because these people don't have ventricles, they don't have QRS complexes, because the heart rate is determined by what you've dialed into the computer, there's no point in monitoring the EKG, so you unplug the EKG in patients that you monitor in these patients, because there's nothing there. So you have an A-line tracing, a central line tracing, and a pulse ox tracing. There are some centers that are inserting a lot of these. By far the most common continuous flow device is the HeartMate 2. On the Bottom here, I've got a nice little cartoon from the manufacturer. This is a figure from a very nice paper. Once again, a large diameter inflow cannula into the device, a bend, the impeller, an outflow bend, and a long aortic cannula. This is what a chest X-ray of what one looks like in a patient. If you kind of zoom in on that, this is the internals. And so the most important thing to know is the inflow's over here, and once again, you're generating negative pressure here that gets transmitted to the ventricle, up to the left atrium, and even into the pulmonary veins. There's enormous positive pressure on this side. The inflow into the pump determines the outflow of the pump. Basically, this pump will generate as much forward flow as you give it inflow. The salmon and yellow things right here, these are the bearings that will fail in these devices over time. This is once again why people are going for bearingless devices. This is what the control panel of one of these looks like. This is a photograph I took on our ICU. It tells you what the flow is, the cardiac output in liters a minute, how many RPMs the patient's got dialed in, what their pulsatility index is, what that is I'll explain to you in just a minute, and how much power it's consuming. There's a newer portable console. This is what it looks like. You actually have to take 3 different pictures of it if you're using an iPhone, as I did. This is the same patient. So this is what you kind of see when the room is dark, right here. Just the flow, and you can scroll through all the different screens there. Here are all the alarm lights lit. I'm testing the console there on that same patient. And that's what it looks like when you let the screen go dark, which is what it does most of the time. The second most common left ventricular assist device out there is the hardware, often referred to as an HVAD as opposed to an LVAD. It's tiny. You can fit it in the palm of your hand. Here's one standing next to a battery. Right over here, this is what an X-ray of what it looks like in a patient. You can see basically you plug this in to the ventricle of interest, generally speaking, left ventricle. It sucks the blood out of the ventricle and it pumps the blood out of an outflow tract. One thing I'm going to point about the HeartMate 2 is you tend to program this device to turn around 9,000 times a minute, which means every time this screw turns, it pumps about a half cc of blood. So the kind of turn volume of this device is about a half cc. So generally speaking, your cardiac output, your forward flow, will be about literally a half cc per turn of the rotor. A little bit different with the heart-wear. With the heart-wear, you've got these 4 veins in the rotor here, and each of these pumps about a half cc. So you get about 2 cc's of forward flow for every time that rotor turns. So here's the console on our heart-wear in a different patient, and you can see once again 2,600 rounds per minute, revolutions per minute generates about a 5.7 liter forward flow. This device tells you the watts. It doesn't tell you what the pulsatility index is. It tells you how much power it's consuming. It could tell you what the pulsatility index is, but this company doesn't have the intellectual property required to do that, and so it's hidden in the machine. This is what the portable console looks like. Once again, it's got an LCD screen that kind of goes light and dark. I put this slide in at a cut and paste from a journal article from several years ago, actually just last year. The problem I have with it is that the people who actually published the journal screwed up the aspect ratios on all of these X-rays. So they're all taller, or all these images, so they're all taller and narrower than they should be. But I put it in just kind of because the author here did a very nice job of basically penciling in the outflow cannula of both of these devices, and you just get a sense of how long they are from the device to where they're typically kind of inserted into the aorta. This matters because there's once again an enormous pressure drop across these inflow cannula. Remember that your ventricle, right, is just pumping blood across the aortic valve into the aorta, so it's a huge difference compared to your natural physiology. Another continuous flow device that's in clinical trials is the Heart Assist 5. This is one of our ICU nurses holding on our Heart Assist 5. This is the first Heart Assist 5 implanted in a patient in North America. The advantage of this device compared to the HeartMate 2 is that the HeartMate 2 is actually implanted extraperitoneally in the abdomen of people. This device is actually intended to be implanted in the pericardium of people. So literally this entire operation happens in the chest. There's an inflow cannula, the impeller of the device. It's actually got a flow meter built into it. That little block right there is the flow meter in the outflow tract. It's got a smaller impeller than even the HeartMate 2, and so the idea here is it'll have a little bit more pulsatility. It's actually got 2 different inflow cannulae, 2 different outflow cannulae, so you can insert this in very small patients, as small as 35 kilograms. So basically even adolescents can get this device. It's in clinical trials, like I said. The HeartMate 3 is also in clinical trials. We're inserting them at my shop. This is a device that structurally speaking, is very similar on the inside to the heartware that I've already showed you a photograph of. It's made by Thoratec. Once again, it's got magnetic levitation on both sides, which they're very excited about because they believe it's going to be associated with less thrombosis. And it's a device that is, in many respects, probably completely interchangeable with a heartware. Next up in the world at large is going to be this device, which is called the LVAD. And the LVAD is going to be inserted by thoracotomy. So unlike all the rest of these devices, which require a trip to the operating room, a median sternotomy, a cardiac anesthesiologist, a bypass run, this is a device that our surgical counterparts will be able to do a left thoracotomy, insert this device, just basically stab the left ventricle with it, open the pericardium, bring the inflow cannula or the outflow cannula up to the aorta, do a side bite on the aorta, anastomose it to the aorta, and they're done. So this is going to be a much less substantial operation than the implantation of any of these other devices. And that will be a game changer because instead of having major cardiac surgery, this will be something that you could do in anybody. The other thing that will do, probably, is make it so that our threshold for inserting these devices is going to be significantly lower. So this device, if it actually pans out, and we don't know if it will or not, if this actually happens, you will see this device used far more liberally than any of its alternatives. One of the trajectories over time is that these devices have gotten smaller. This is a fabulous figure from a paper published in Heart last year. So there's the HeartMate XVE, like I said, my original favorite device, about as big as a small dinner plate. There's the Thoratec PVAD, there's the Thoratec IVAD, there's the HeartMate 2, there's HeartMate 3. You can see these devices have gotten nothing but significantly smaller over time. There's the heartware, and right here, this is the LVAD, and you can see that the LVAD is basically, it looks like a T-piece on the outflow cannula. Think about it, that device, that's the trajectory of 20 years of device development. If you look at the numbers, here's a very nice table from that same paper. So there's the HeartMate XVE, here's the PVAD, here's the HeartMate 2, here's the HVAD, here's the HeartMate 3, and down here, here's the LVAD. You can see you've gone from something that weighed over 1 kilo in weight down to a device now that weighs about 75 grams. That's like 2 shots of whiskey if you're an Irishman. You've gone from enclosed volumes that are 390 mLs down to an enclosed volume that's about 15 mLs, about half a shot glass of whiskey. You could literally take several of these devices and actually insert them in the chamber of a HeartMate XVE and have some room left over. It's impressive how much these things have changed. Everybody knows that it's patients who have cardiomyopathy who get these devices. I will point out that people who have an ischemic cardiomyopathy tend to have all of the blue complications on this slide. They bring a lot of comorbidities with them. People with the non-ischemic cardiomyopathies have typically comorbidities that are characteristic of whatever their disease process was. At my shop, peripartum cardiomyopathy, alcoholic cardiomyopathy, autoimmune cardiomyopathies are by far the most common indications for the dilated cardiomyopathies. We're not yet putting these into patients with muscular dystrophy or Ehlers-Danlos or anything like that. I have no doubt that as these devices get smaller and the morbidity and mortality of inserting them gets lower and lower, you're going to start to see us using these devices in those kinds of patients. There's been a change in the jargon or the terminology that people use with these devices. We used to say that patients had either a bridge to transplant device or a destination device. Nowadays, my heart failure colleagues prefer to use the phrase short-term and long-term. Short-term with the idea being that this patient either is believed to be a good candidate for heart transplant or is going to be evaluated for heart transplant. I will tell you that at my place, we've actually retreated from using LVADs as a bridge to transplant these days. If we think you need a heart transplant and you're in cardiogenic shock, you're far more likely to get a subclavian balloon pump and kind of walk around my hospital on dobutamine, dopamine, milrinone with a balloon pump rather than get an LVAD. And the reason is because explanting any of the LVADs, even the current generation LVADs, is such a bloody and difficult proposition in the operating room that we've just gone to the subclavian. The other thing is that the rate of driveline infection is so high, about 40% in patients who have these devices, that you don't want to go ahead and explant a patient who has a driveline infection, drop a heart in them, and then start them on quadruple immunosuppression. So to avoid that kind of complication, we've gone to putting subclavian balloons on some people. So at my shop, most of the LVADs we insert are what we call long-term devices. Now, how well somebody does is largely determined by their Intramax criteria. We've actually stopped or retreated from inserting these devices in people who are in critical cardiogenic shock because the mortality is so high. It's about 70%. So they've gone from about 30% of the people who get these devices down to about 15%, probably headed towards 10% at many centers. And most of the people who get these devices are Intermex 2 or 3. Basically, they're requiring inotropes, and they're not really doing that well. And those people have pretty good outcomes. Many people think that it's not ethical or appropriate to insert these devices in patients who are Intermex 6 or 7. There are centers that do that. I have no doubt, once again, as these devices get smaller and there's less morbidity and mortality associated with inserting them, you're going to see their use creep down to the bottom of this list. I will point out as well that there are no continuous flow devices approved for the right ventricle yet. This is important because in many of our patients, their RV isn't much better than their LV, and sometimes it's just as bad. And the manufacturers and the FDA haven't been hugely interested in the right ventricle thus far. Having said that, this is a patient at my shop who has 2 different heartwares, one in the left ventricle and one in the right ventricle. And many centers do that. If somebody needs an RVAD, they'll either put a Thoratec in, which is an approved pulsatile device, or a heartware, that's an off-label use of the heartware. Why do we put these devices in people? I'm going to go through this fairly quickly. This is data from the original Intermex trial. It's a Kaplan-Meier curve. You can see the people who got the LVADs have the great survivorship out to about 18 months, and the people who got medical therapy did not. This study was a game changer in 2 ways, one of which is nobody appreciated what the ridiculous mortality was in people with New York Heart Association 3-4 heart failure. If you look, once again, at 18 months, 90% of these people are dead. All right? You'd much rather have widely metastatic lung cancer than New York Heart Association 3-4 failure. You have a much better chance of living 5 years, even 20 years ago. So it's really important. Medical therapy, which has not gotten better since this trial was published, is not associated with a significant improvement in survivorship, and the survivorship of these patients is generally dismal. Why do these devices fail after 18 months? This is a study of pulsatile devices, and the valves tended to fail at around 18 months. So between 18 and 24 months in this Kaplan-Meier curve, the reason that all those patients are dying is because their devices are failing. Yes?
Can you speak a little louder? It's hard to hear.
Are you guys having a hard time to hear me? All right. I'm sorry. There are so many of you. You could all just come to the front. We could actually sit down here. This is the Rematch 2 trial published in the New England Journal of 2009, and this is really what brought about the modern era of the LVAD. These are continuous flow LVADs here. Here are the pulsatile devices, and as you would expect, at 18 months these devices start to fail, and so that's why these Kaplan-Meier curves especially separate here. But there was a significant early survivorship advantage to these devices, and as a consequence, everybody believes that continuous flow devices are the way to go in the future with these patients. This is what we call the forest plot from this trial, and you can see that any way you cut the data with the questions that they asked with this trial, the continuous flow devices were better. I will tell you that there was one thing that they didn't think of where the pulsatile devices were clearly superior, and that was GI bleeding. GI bleeding. There's a huge rate of GI bleeding with these continuous flow devices that was not present with the pulsatile devices. And that's one of the reasons why we'll be having this talk today. But it's impressive because every question they thought of when they started this trial, the continuous flow devices were better. Now, this is very nice data from Starling. And basically it shows that in Starling's hands, the HeartMate 2 was better than all of its alternatives. They were all pulsatile devices when he published this study. And you can see that out to 1 year, he had an 85% survivorship with continuous flow devices, basically a HeartMate 2. This is actually how Starling's patients do. You can see that about a third of them get transplanted, about 1% of them get explanted. That 1% that get explanted, by the way, they have by far the best outcomes of anybody who has an LVAD. About 15% of his patients died in the first year, and about 50% of these people had ongoing support with these devices. This is important because when you see a Kaplan-Meier survival curve in these patients, it includes people who get explanted and it includes people who get transplanted. And I actually prefer to present the data this way. This is the intellectually honest, legitimate way to present this data. This is what I'll call a propaganda figure. And it compares the Kaplan-Meier curve from rematch 2, which is the red line, to the medical management curve from rematch 1, which is the blue line. And it just demonstrates that the continuous flow devices are so vastly superior to medical management. And that's why we see so many of these devices going into people with advanced heart failure, because they have not just this incredible survivorship. But the real reason that people get these devices is because if you get medically managed for New York Heart Association 3-4 failure, you've still got severe heart failure. Whereas if you get a mechanical assist device and you have a good outcome, you end up having a New York Heart Association 2 functional status. So you go from being short of breath walking from your kitchen to your living room or from your bedroom to your bathroom to being able to basically do anything except run a marathon with these devices if you have a really good outcome. And so it's really important. One of the reasons why patients are so enthusiastic for these devices is because there's a dramatic improvement in functional recovery that's significantly better than what we get with medications. That's important because when we talk with these patients preoperatively now, they get a palliative care consult. And we talk with them about what their goals for getting the device are. And most of them will say, and by the way, when I stop getting this functional benefit, turn off the device and let me go. And so with many of these patients, if they have a devastating complication, when they reach the end of their time, their families, everybody understands, here's the criteria we created, it's time to stop. It's very nice, it's very important. There's a huge community of these people online. They've got their own discussion boards, they've got their own blogs. This is a guy who got his LVAD at one place, transferred his care to another place. This is his blog posting about how to go fishing with a car battery attached to you. He has actually subsequently gotten a heart transplant. He's doing really well. But it's funny, HIPAA prevents us from talking to these patients about each other. But you know, if you take care of these patients, you will have, your name will be all over these discussion boards. These people know who all of us are who take care of these patients. We'll talk a little bit about how these devices change a patient's physiology. We're going to talk about how a diminished pulse or no pulse changes your physiology. We'll talk about anticoagulation and acquired von Willebrand's disease. The first thing to know is it's 2016 and we still basically start with heparin and transition to warfarin. Other alternative strategies for anticoagulating these people are being evaluated. The actual targets for anticoagulation are a work in progress. They're changing. There's the PREVENT registry trial that's kind of interrogating basically more or less anticoagulation, early versus late anticoagulation. Reversal right now in the modern era is still FFP. With these devices, flow is estimated from power consumption. It's very important. You dial in the RPMs. The device uses as much power as required to generate that number of RPMs, and then it calculates the flow. And so what happens is, this is a figure published in this paper of a HeartMate 2, but you could create a figure like this for any of these devices. On the x-axis is RPMs, on the y-axis is power consumption, and then literally this would be a grid of flows. And with this device, the low flow is about 3, the high flow in this figure is about 7.8. If you fall below the black line, you get a minus, minus, minus. The device will not report a flow. The device is doing what we call freewheeling. It cannot explain how it's generating that many RPMs with that little power. Generally speaking, it's a consequence of very low resistance downstream. The red line is what it considers to be the peak of appropriate power consumption. If it's using more power than that to generate flow, as far as the device is concerned, there is some internal problem with increased resistance. This is a device that has a bearing failure or a device that has a thrombosis. And what you'll get is a plus, plus, plus. In between the red line and the black line, the device will actually report out numbers. All of these devices could have a curve like this that you could paste in your conference room just like we have. The pulsatility index is very important. The outflow of these devices is determined exclusively by their inflow. The device will pump pretty much as much blood as gets into it. And so when the LV contracts, and in most of these patients the LV will still contract, when the LV contracts, it'll actually augment the inflow into the device. That in turn augments the outflow of the device. So when you see pulsatility on the arterial tracing of these devices, generally speaking, that's because the device outflow has been augmented by left ventricular contraction. If the LV is full and contracting well, you'll have a lot of pulsatility in the outflow. If the LV is empty or it's stopped contracting altogether, you'll see minimal or no pulsatility. So it turns out that the pulsatility index is a very good measure of the filling volume of this device. And so generally speaking, a normal pulsatility index is about 6. Here's a nice figure, 3 different echocardiographic techniques. Here's a high pulsatility index. They turned up the RPMs, it went down. They turned up the RPMs a little bit more, it went away completely. The other thing that happens, right, is that the device, if you turn up the pump speed, if you turn up the RPMs and you try to increase the flows, you'll get less augmentation of inflow with left ventricular pumping. Now, I tell people the circulation actually has 3 pumps. It's got the veins that pump blood back to the RV, which pumps blood to the LV. And it's important because when we insert an LVAD in a patient, all we've done is replace the left ventricle with a mechanical assist device. We still have to manage the venous pump, and we still have to manage the RV. And that's important. It's a very helpful way to think about their circulation as you think about the circulatory consequences of implanting these devices. The mean arterial pressure is created by the LVAD, and it's also the pressure against which it pumps. It's very important. If somebody has a mean arterial pressure of 140 or 150, the device is going to use a lot of watts, and it's going to run really hot. If it's got bearings, it's going to fail. That's one of the reasons why we tend to target mean arterial pressures over the long term with these devices of somewhere in the 70 to 80 or 70 to 90 range. The aortic valve, generally speaking, doesn't open in these people, so it's continuously subjected to what we would call pressures in excess of normal diastolic in these patients. And this is why aortic insufficiency is a fairly common complication of having one of these devices in for a long term. Fontan flow, that is to say flow in spite of an RV that's not contracting, is possible with these devices. If somebody has straight up cardiogenic shock, has an LV that fails and an RV that was otherwise normal, they'll have a normal pulmonary vascular resistance. And so if they have asystole, VTAC, VFib, and a normal pulmonary vascular resistance, often they'll have forward flow in spite of the fact that they have a non-perfusing rhythm. If they've got significant pulmonary hypertension, then passive flow will be insufficient to generate a forward flow through their right-sided circuit. Very important. High pump speeds can suck the septum into the inflow tract, particularly in hypovolemic patients. I'll show you a couple of snapshots from an echo a little bit later in the lecture about that. And the venous return matters, and so the volume matters. The RV outflow is the LVAD inflow. Very important to understand that we manage the volume, the contractility, and the afterload of the RV. Many of these patients, their RV is not much better than their LV. You pop the device in and you discover, oh, by the way, their LV was not much better than, or not much worse than their RV. The mean arterial pressure perfuses the RV. It's very important. With people who have an RV limited circulation, you need to defend their blood pressure because that's what perfuses their RV. And their pulmonary vascular resistance still matters. It's very important. Oxygen and sildenafil are very common drugs that we use to support these people. RV failure kills in these people. This is a very nice figure from Morgan from just a couple years ago. And you can see this is the Kaplan-Meier survival curve in this study of people who have LV failure, and you can see it's pretty darn good. It's 85%, right, at 18 months. Whereas if you look at the people who have RV failure right here, 40% of them dead within 60 days. RV failure is a highly fatal surprise complication of inserting these devices. This is, once again, the Kaplan-Meier curve of people who do fine. Here are the people who did well with just milrinone. You can see there's this phenomenal survivorship. Here are the people in the study who got an RVAD. You can see the mortality in people who get an RVAD shortly after they get an LVAD is about 70%. So needing an RVAD after you get an LVAD, it's a highly fatal complication. These devices, they're basically blenders inserted into the circulation. All of your blood is passing by a rotor or a blender blade that's turning somewhere between 2,500 and 20,000 RPM. And as a consequence, it tends to slice and dice your red cells and everything else in your circulation. And one of the things that gets sliced and diced is the von Willebrand's factor. Here's a platelet. Here are the von Willebrand molecules right here. They are so large that you could almost see them with a light microscope. And these get cleaved and destroyed by these devices. So everybody who gets these devices has an acquired von Willebrand's disease, which you can actually cure with heart transplantation. It's the way that they're autoanticoagulated. Interestingly, it does not prevent these devices from thrombosing. Advanced age is associated with a significantly increased risk of von Willebrand's disease. So if you drop LVADs into young people, the rate of von Willebrand's disease, acquired von Willebrand's disease, is about 30%. If you drop them in the older than 65 population, which is now the majority of patients getting these devices, 60–70% of these patients will have acquired von Willebrand's disease. In spite of the fact that they acquire von Willebrand's disease, there's actually a propensity to clot these devices. So this study is the reason that we're actually doing the PREVENT trial. And you can see in the original REMATCH 2 trial, the rate of device thrombosis was something like 15% at 2 years. Very low rate of device thrombosis. After these got approved for more widespread use, suddenly with less aggressive anticoagulation, there was an enormous increase in the risk of device thrombosis. I'll point out to you that if your LDH is greater than 750, you've got about an 85% chance of having your device clotted. If it's greater than 1100, it's about a 95% chance that your device is thrombosed. At our place, we also check the haptoglobin. If it's less than 7, that's also strongly suggestive of device thrombosis. One of the things that we forget about is that these devices are tiny. The impeller on a HeartMate 2 is not quite as big as the last 2 portions of my index finger. And the thrombosis that you need to bring down these devices is incredibly small. So this is a nice figure published in, once again, the peer-reviewed literature. And those clots, they're not quite as big as a match head. A clot that's the size of a grain of rice, a clot that's as thin as a piece of paper adherent to the rotor of these devices is sufficient to produce turbulent flow and device failure. So when people say, oh, this device is thrombosed, don't think of this person as having a tip of your pinky-sized clot anywhere in this device. We're talking about something the size of a grain of rice, a match head, something that's, thin and extensive, like a piece of paper covering some portion of the rotor. Why are you going to see them in your operating room? Bleeding, infection. Here are the complications. Here's the list of the common procedures that are done in these people. I'm sorry, I decided to kind of cut and paste the entire list. We see them a lot in the endoscopy seat. We see them a lot in getting laparotomies and laparoscopies. We see them a lot getting urologic procedures, particularly cystoscopies. Many of the cardiovascular patients have significant peripheral vascular disease, so we see a lot of leg amputations in these people. A lot of soft tissue infections, largely related to their drive lines. I did not include in this one sternal debridement enclosure with flaps, which is right there on the left, just under exploratory laparotomy. So a lot of these cases are done by non-cardiac anesthesiologists. A significant percentage of these cases are done by non-cardiac anesthesiologists, and a significant percentage of them are done in the GI lab or in the bronch suite. Over time, as these patients have longer survivorship, and there are more of them out there. At my place right now, we have something like 180 patients with devices who are kind of orbiting out there. And they come to us for their care, and they require anesthesia and surgery for their cancers, for their other complications of these devices. As we have gotten more comfortable taking care of these people, a couple of things have happened. One of which is our use of A-lines has gone from about 40% down to about 20%. Pretty much typical of what was published here in this fabulous study by Stone. The vast majority of these cases are done outside the operating room. They're in the endoscopy suites, which is why there are 60–70% of them. And the vast majority of those cases are done by non-cardiac anesthesiologists, people like you and me. GI bleeding, like I said, was the big surprise of the continuous flow devices. We believe that what happens is the absence of pulsatility produces angiodysplasia everywhere in the GI tract, perhaps everywhere in the body. And that's the major cause of GI bleeding in these people. Somewhere between 30% and 40% of people who have continuous flow devices will actually end up with a GI bleed. If you actually look at the actual causes, this is a very nice figure from the GI endoscopy literature. I'm going to start here, even though it's the bottom. 22% of the time, we have no idea what's causing the GI bleeding. 29% of the time, we say it's GI angiodysplasia, which means we see angiodysplasia, but we can't find a distinct lesion. And then interestingly, 22% of the time they say it's gastritis, which is their way of saying, we see angiodysplasia, we can't find a specific bleeding lesion. So the vast majority of the time when these people have a GI bleed, you're not going to have a discrete cause of their GI bleeding. The most common cause that people identify is an ulcer in the upper and a diverticular disease in the lower. Rarely you'll find a polyp or you'll have a diagnosis of colitis. Very important. Most of the trips to the endoscopy lab for these people are going to be non-diagnostic. A couple of other things, one of which is you don't GI bleed with these devices right away. Typically, it takes about 3 months for people to have their first bleed because it takes time for them to develop their angiodysplasia. can happen as soon as a couple weeks, but most people it's about 3 months. Once they've had a GI bleed, it does not matter what you do with their anticoagulation. If you back off to extraordinarily low levels of anticoagulation, it won't matter because they're bleeding because they have AVMs, not because of their anticoagulation. And that's why in this study, the mean INR at time of rebleed was 1.5, basically upper limits of normal. You can almost hold anticoagulation in these people, and it will not make a difference. This is a copy of my institution's policy for the use of 4-factor prothrombin complex concentrate. And when we reverse these people, unless they've bled into their head, unless they've got an intracranial bleed, we use FFP and FFP alone. We don't use vitamin K, we don't use prothrombin complex concentrate. And the reason is because if they thrombose their device, they're probably going to die. All right, and so we tend to creep up on what we think of as the target anticoagulation that we have with these people just with FFP. Because if they're bleeding, we can transfuse them. If they clot their device, that's a fatal event. So many of these patients, you know, they're in your care because they've got a stomach full of blood. Often they've got an elevated INR, and so your job is to kind of give them red cells and FFP to fix that. Many of them have had a trach. Some of them will have tracheal stenosis. There's more tracheal stenosis in these people than in anybody else I've seen with trachs. Anybody who's got ischemic cardiac disease is a vasculopath. They can be hard to get A-lines in. And you've got to ask yourself, do I need to burn this person's radial artery for this procedure? Often the answer is no. Sildenafil, milrinone, and midodrine all tell you that the RV is failing, and that's important because that's a high mortality complication. Patients with an RV-limited circulation are also tend to be kept very, very dry. And so when you meet them and feel the urge to give anesthesia to them, it's appropriate to expand their circulating volume. Whenever you can, you should plug their drive console into the wall. That is, say, wall power is always better than battery power. The wall will not fail you, the battery may. Your goal mean arterial pressure is at least 70 to 80, because once again, you want to perfuse the RV in these people. And it's okay to run high. If you run a mean arterial pressure of 100, 110, 120, all of the modern devices will be fine with those kinds of pressures for the short term. Hypertension is a long-term problem for these devices. It is not a short-term problem for these devices. Generally speaking, because these people often have an RV-limited circulation, spontaneous ventilation is always better than mechanical ventilation. They will always do better breathing on their own. And if you have to ventilate them, you want to ventilate them with the least tidal volume, the least minute ventilation, and the least PEEP that you can get away with. All right? These are people who want to ventilate the least you possibly can. So pressure support with CPAP, once the tube is in, is a great way to ventilate these patients. The hardest thing in monitoring these patients is assessment of their volume status, and so use the pulsatility index. If your patient has a HeartMate 2 or another device that reports to a pulsatility index, aim for a pulsatility index of 6 or 7. That's what you can represent as euvolemia in these people. That is a much more reliable indicator of the appropriate circulating volume than anything else you can measure. It's better than a wedge pressure, it's better than a CVP. This is what you want, because this is what's determining the inflow into the device. Many of these patients come to you quite dry. Many of them are bleeding into their GI tract, and you cannot see it. With respect to monitoring, the pulse ox will work. The blood pressure cuff will work. Sometimes you need to turn down the pump speed to get these things to work better. Most patients have some pulsatility. If they're pulseless, either their LV is dead or they're really hypovolemic. So if somebody has no pulse, give them volume. Find out if they've previously had a pulse. But anesthesia and shock tends to make people pulseless, right? And so we end up having to resort on these things. I will tell you the following, and that is that if you have somebody who has an LVAD, who has no pulsation, and who's a vasculopath, who you've been using a blood pressure cuff to measure their arterial pressures, right? Sometimes under general anesthesia, the only way you know these patients are alive is they're making CO2. It's very important to understand. You know, so I find myself with the ultrasound machine and I'm Dopplering the carotids if they're working in the abdomen, and I'm Doppling the arm or the leg if they're working on the head and neck in the endoscopy suite. Because you can see color flow when there's forward flow, and when the color flow goes away, you know you have a problem. Now, one of the things that you can get with hypovolemia in these people is suction events. And with a suction event, what happens is this inflow cannula is suctioning blood out of the LV. And you've got this fabulous inflow, and here's a very nice ultrasound of this. But if you get hypovolemic, what will happen is the suction of the cannula will actually suck the septum into the lateral wall. You'll get fluttering inflow into the device, so you'll have a change in the inflow of the device. When that happens, the septum's been sucked over, the RV dilates, the tricuspid valve dilates, and you get tricuspid regurgitation. And so the device will chatter and it will alarm, and the response to this is to give volume, and if that doesn't work, turn down the flow, or turn down the pump speed. But generally speaking, the most important thing you can do in these people is give volume. This is what a suction event looks like. This is another image of these things. And so here's a patient who's actually having one. So you can see the RV is over here. Here's your LV, nicely filled. Then you get a suction event. What happens is Bernoulli sucks the septum over here. And so here's the LV cavity. You can see that it's incredibly narrow. This patient has no inflow into their device. This person's in shock. The thing to do is to give them volume and turn down your pump speeds. You can see the RV is nicely dilated here. With respect to crisis management in these people, the most important thing to remember is that if they don't have an LVAD, you need to manage the RV. The mean arterial pressure perfuses the RV. Rhythm matters for the RV. People who have LVADs in do best in sinus rhythm at a perfusing rate. All right. When I was young and dinosaurs roamed the earth, people were concerned that CPR might dislodge these cannulae. There are now studies in literature that say, yeah, actually, you can give these people CPR. This is one of them. This is published by Schmar. It's from a couple of years ago. And this is a study of 8 patients who came to CPR. None of them had dislodgement of their cannulae. None of them. This is a very nice images from that paper. What it demonstrates to you is that the RV is right there where you need it to be. So the RV is the target of your perfusion. It's right there. You can compress it with chest compressions. So don't hesitate to give chest compressions to somebody who's got an LVAD, particularly if it's been in for a while. These modern LVADs are so small, you're probably not going to dislodge any of these cannulae. Now, people have been thinking about ACLS of these patients. There are so many of them out there that, in fact, the heart failure people have published guidelines about how to do ACLS in people with LVADs, published in the European Journal just last year. Go ahead and take a photograph with this slide. And this is their algorithm, which is, basically, the patient's got a crisis, activate your code team, have somebody go ahead and fix any LVAD malfunctions that might be there. If the patient's got a shockable rhythm, that is, say if they're VFib, SVT, VTAC, shock them. If they're not shockable, Doppler for blood flow. Like I said, many of these people, the only way you know they're alive is if they've got Dopplerable flow. If they don't have Dopplerable flow, you need to go ahead and put lines in. If they do have Doppler flow, you need to go ahead and don't activate the stroke team. Over here, what happens is, you go ahead and resuscitate them. And if you can't resuscitate them, in the modern area, you put them on VA ECMO. And that's exactly what we do at my place. These people end up in a circulatory crisis. We can't sort out what's going on with their LVAD and their heart. We'll take these 2 4-French cannulae that you put in the femoral vein and femoral artery, convert them to ECMO cannula, just put them on ECMO and sort it out. And that's really important. Most people who have an LVAD in who are perceived to be viable aren't going to die until they've had a course of ECMO. All right. My colleague Alan Klock has said, every time I take care of an LVAD, this is what I'm going to have in the room. And so this is what I call Alan Klock's LVAD toolbox. I encourage all of you guys to assemble all of this stuff if and when you're taking care of a patient who's got an LVAD. An ultrasound machine with color Doppler, because it will help you assess whether the patient's alive, as well as measure the blood pressure. A true central line, which is going to be your access to go to. A femoral A-line kit, whatever you use at your shop. Norepidobutamine and vasodrips. A TE machine, and a defibrillator. In the modern era, there are kind of 2 other complications of these devices that we're seeing, one of which is we're actually studying the actual speed we're running these devices at with what we call a ramp study. The second thing is that we increasingly are discovering that these people have problems with their cannulae. And so they're going to the CT scanner to get high-res CTs. And here's a very nice picture of one. So this is a kink right there in an outflow cannula, and this is a 3D reconstruction. You can see there's a kink in the outflow cannula right there. And so that's important because our cardiac surgery colleagues, or our cardiac anesthesia colleagues, are increasingly seeing these people in the OR for revisions of these cannulae. Finally, the last thing that you need to know about is aortic insufficiency, which is an insidious and still difficult to diagnose complication of having these devices. This is a figure created by myself, I'm sorry. Basically what happens is, here's an LVAD, and here's the patient's left ventricle. And the device is sucking blood out of the LV and into the device. It's pumping blood up its enormously long and narrow outflow cannula, and you got a pressure of plus 80 here in the aorta. Now, in all the distal arteries, the subclavians, the carotids, and of course the body, those are all high resistance circuits, and there's not a lot of opportunity to run off there. On the other hand, on the other side of the aortic valve right here is a pressure of minus 20. And so with this device, it pumps 5 liters a minute here, there's a pressure of 80 here, and there's a pressure of minus 20 here. Where does all the flow go? It goes backwards through the aortic valve into the LV. Very important. The device will say, I'm spinning at 9,000 RPM, I'm pumping 5 liters a minute, and everything is good, and I'm really well filled. You'll measure the patient's blood pressure, they'll say, you know, they're moderately hypotensive. They've got a mean arterial pressure of 60 or 50 or 40, but they're mottled, and they're cold, and they've got a lactic acidosis. This is aortic insufficiency. And you know, these people will come to you from the ER, they'll come to you from the floor, they'll be in crisis. People will say, you need to do something for this. One of the things that you need to do is you need to get somebody to get an echo and make sure that the aortic valve has not failed here. You know, in the modern era, so this used to be a highly fatal complication because you used to have to take these people to the operating room and replace their aortic valve. Some surgeons took them to the aortic valve, took them to the operating room, and instead of replacing the aortic valve, just sewed it shut. In 2016, when somebody has aortic insufficiency with an LVAD, we're now diagnosing it early. When they have mild aortic insufficiency, we'll fix it, and what we'll do is we'll do a TAVR in them. We'll do a transleft ventricular or a transcarotid TAVR in these people, which is a definitive treatment of this as a problem. But you will still see people who have these devices in who come to you with typically an infection-related aortic insufficiency and this crisis. And the person who's most likely to diagnose it is going to be one of the people in this room. Most people who have these devices have already articulated that, you know, they don't want to go on in a dismal state. And so we end up stopping the device, changing our goals of care when they have a hemorrhagic stroke, when their RV failure has produced a situation where they have no benefit from having the LVAD, when they've got a cause of bleeding that we can't stop, when they develop sepsis and an infection organ system failure. It's very important. And once again, these are easy people to withdraw care on because they and their families have criteria before they ever get the device about when it's time to stop. So what do you need to know? You need to know that most modern devices are continuous flow, that as they get smaller, you're going to see us be more liberal in inserting them, and that people who are less sick and have a higher functional status are going to get them earlier in the course of their heart failure. The long-term indication for these devices is going to be principally an LVAD. How do these devices change a patient's pressure? Change a patient's physiology? They have much less of a pulse than they did before they had the device. The RV continues to pump. That matters to you. They all have acquired von Willebrand's disease. What are the complications? The number one reason you're going to see them is GI bleeding or some sort of abdominal disaster, RV failure, stroke, respiratory failure. What are the clinical implications of all this? The stomach is going to be full of blood. You should plug in the device when you meet them. You should manage the RV because it's your problem. You need to manage their AICD. You already know how to do that. Doppler their blood pressure or put an A-line if the non-invasive blood pressure doesn't work. Maintain normal sinus rhythm because that's what maintains the circulation with their RV. Defend the mean arterial pressure. Have a floor of 70 or 80. Use the pulsatility index of the device if it reports it to you as a way to assess their volume status. If they have a suction event, give them volume. If they need ACLS, do it. Remember that they should always be making CO2 if they're alive. And if they're not making CO2, they're dead. We would rather they bleed than their clot. Don't give them vitamin K or don't give them prothrombin complex concentrate unless they're bleeding into their brain. And you'll know when it's time to stop. And with that, I will take any questions that anybody has. Thank you for your attention.
I have 2 questions. The first one is, you showed data showing that the survival is better with continuous flow devices than pulsatile devices.
Right.
But then, if I understood correctly, you said the LVAD, who is a newer device, is pulsatile.
Well, it has more pulsatility. That's correct. So the pulsatile devices had valves in them. And the problem with the valves is the valves are mechanical devices that fail. Classically, they were actually, believe it or not, bioprosthetic valves. And they would only last about 18 months. When the valves failed, the device failed. People have realized that the angiodysplasia is a consequence of the continuous flow. And the belief is that with more pulsatility, you will have less angiodysplasia, less GI bleeding, perhaps better RV performance. And so that's why people are looking for these really tiny impellers or rotors, really lightweight, greater pulsatility, basically changing the forward flow of the device as the LV contracts.
So the idea behind the LVAD is to be slightly pulsatile but without valves.
That's exactly correct. That's why all the smaller, lighter rotor devices will have greater pulsatility.
My other question was about, you said that needing an RVAD after an LVAD is a very ominous prognostic sign.
That's correct.
What are the clinical symptoms, signs that induce you to think that the patient needs an RVAD after the patient has had an LVAD placed?
So as you can imagine, this is a domain in which the literature is still quite active. That is to say, we don't have definitive answers to this. But for myself, at my shop, the one thing we use is the pulmonary vascular resistance. If somebody has that elevated pulmonary vascular resistance, they're very likely to need an RVAD post-operatively. They're likely to have an RV limited circulation. If they have a normal pulmonary vascular resistance before they get their LVAD, they're not going to have RV failure. The higher their pulmonary vascular resistance, the greater the possibility. And at some point, you should say either we should just put an RVAD in this person, or we should just not do this. Now, many people say, well, what we need to do is we need to just put a BiVAD in this person. Okay. The problem with that is that's also a high morbidity and mortality proposition.
But so do you have a Swan-Ganz in these patients to measure PVR?
All these people get a left heart and right heart cath in the cath lab before they get their device.
Okay. But so for instance, so you know the PVR before, right? But you still put the LVAD and then you wait. I mean, and then you decide and you say, like, is a patient hypotensive with the LVAD? I mean, is that what makes you decide? Or
so often you've got high right-sided filling pressures. You've got relatively empty LV. The device is struggling to fill. And when you get an echocardiogram, you see a dilated, poorly functioning RV. And you say, okay, that's it. So prior to putting the LVAD in, often if you have high PA pressures, an RV that's not doing that well, people say, oh, well, the reason is because it's congestion from the left side.
okay.
So when you decompress the left side with the LVAD, then you unmask whether this is reversible or irreversible. If it was reversible, that's a win. Everybody pats themselves on the back and goes home. If it wasn't reversible, then you find yourself managing all this stuff. And right now, we don't have a huge ability to predict in whom is it a consequence of LV failure and in whom is it a consequence of a perhaps over a long time increase in a fixed elevation of the PVR.
Thank you.
Hi, I'm Mark Nelson from Virginia Commonwealth University. Wonder if you could comment on a non-cardiac anesthesiologist do a fair number of these. Are those basically the GI cases and the more simple things, or do you tend to favor cardiac anesthesiologists doing bigger cases, like we had a cystectomy in a patient with a VAD, so we had a cardiac person do that? First question. Second question is, how do you manage, is it a VAD coordinator or the perfusionist that needs to be with them when they're kind of in and out? Because at our shop, there's all this debate that perfusionists say, we don't want to be there, we don't do anything, we don't turn the knobs, why do we need to come in? The VAD coordinator says, I don't go to the operating room. And the PACU says, we don't recover VADs.
Gosh, we've never had that conversation. No, what we did is we have trained literally all of the nurses in our GI endoscopy lab how to manage these devices. Because we have 3 or 4 of these cases every week in our GI endoscopy suite, at least. So it's not like, oh, we'll train them and they'll never see it. It's like, we're seeing it all the time, we may as well train them. So all of my GI endoscopy suite nurses know how to do this. Their prep recovery nurses know how to do this. When we do one of these cases in the OR now, we will actually pull the GI prep recovery nurse up to the OR to help the OR nurses manage the LVAD. You know, with respect to, is it non-cardiac anesthesiologists or cardiac anesthesiologists who do the laparotomies, the cancer operations, the cystectomies, the amputations, the soft tissue debridements? At my shop, it's the non-cardiac anesthesiologists. Now, I will tell you that for me, doing a laparotomy on somebody who's got an LVAD is not that hard. Doing a laparoscopy on somebody who's got an RV-limited circulation with an RVAD in, that's hard. And so for me, if we're insulating the abdomen, I'll say, you know, a cardiac guy needs to come and do this case. If it's anything else, myself or one of my ICU colleagues are pretty comfortable doing it. But you know, what's the right answer? I think it depends on your volume and your crew. And so there is no one prescription for how to do this.
How about the LVAD coordinator issue versus perfusions? How do you manage that?
So we have a lot of LVAD coordinators. So we almost always get an LVAD coordinator in. But once again, my GI endoscopy nurses are now trained to do this. So what happens is they'll talk to the LVAD coordinator on the phone, and they will do whatever we decide is going to happen. Yes?
Thank you for great lecture. As respiratory management for patients with LVAD, you recommended minimal mechanical ventilation with lower tidal volume or lower respiratory rate. But I think this lower minute volume management may cause higher PaCO2, and then it may cause pulmonary hypertension and worsen the pulmonary circulation or alveolar failure. So how should I manage them? So I think those patients who are under the anesthesia or sedation, their spontaneous breathing is very low. Yeah.
So your concern is that I advocated the least positive pressure ventilation you can get away with. As a consequence, you're concerned that these patients will have respiratory acidosis, that the high CO2s will produce an increase in the pulmonary vascular resistance, and gosh, golly gee willikers, can't that produce the very problem of an RV-limited circulation that you've told us is associated with such a really bad outcome? All right, so now I'm going to be my contrarian self. I'm just going to take off my regular hat and I'm going to put on my contrarian hat, all right? People talk a lot about the effects of high CO2 on the pulmonary vascular resistance. It's all bunk, all right? I have people who have COPD, who have cor pulmonale, they have a COPD exacerbation, their CO2 goes from 60 to 120. Do those people die of an RV-limited circulation? Never. It's hypoxia that's the most important determinant of the pulmonary vascular resistance. If they're not hypoxic, they're going to be fine. All right, and so from my view, the respiratory acidosis is a trivial consideration relative to the fact that the positive pressure is compressing every pulmonary artery, every pulmonary vein, and every pulmonary capillary in these people. If they're not hypoxic, whatever ventilation you're giving them is probably enough. Okay? Other questions? Thank you so much for your attention.